First of all, welcome everybody. We've got quite a few people registered, over 140 people registered. I'm going to be introducing Santosh and David, and I can see that about people are still logging in quite quickly. And so obviously it does take a little bit of time to log in, but I think I might start just because we only have really an hour to be talking. We're running this program for the first time on the webinar series, on the webinar software, so I apologise if there are hiccups on the way. So, welcome to our inaugural webinar for our Living Well with Cancer webinar series. I'm Judith Lacey, I'm the Head of Supportive Care and Integrative Oncology here at Chris O'Brien Lifehouse, and I'm your host today. And I'm very delighted to be starting our series with a topic that's very dear to my heart, which is demystifying integrative oncology. And I'm absolutely thrilled to have my colleagues here, Santosh Rao from the USA. We lost Gabriel Lopez from the US, he may turn up, and Professor David Joske from Western Australia. And they've agreed to join us today, and we'll hear a little bit more about them and from them shortly. With our services all moving online, conferences cancelled, it really made sense to develop a webinar series for healthcare professionals, practitioners, patients, carers, and also for the interested public. So we've got quite a broad audience joining us today. This series is brought to you from the Living Room, which is the home of supportive care and integrative oncology here at Chris O'Brien Lifehouse. Chris O'Brien Lifehouse is a comprehensive cancer centre here in Sydney, Australia. And at Lifehouse, we aim to provide cancer treatment in a way that supports, nurtures, and empowers patients, their families and carers through mutually beneficial partnerships. And integrative oncology, as part of this holistic supportive care delivery, forms an integral part of Lifehouse's comprehensive cancer care. It's complementing the clinical treatments to improve the outcomes for patients from the time of diagnosis through treatment and beyond. Now, we have developed this series, it's new, but we hope this series complements other webinars and podcasts, such as the one that Santosh runs on integrative oncology for the Society of Integrative Oncology, a great podcast series, and other podcasts and webinar programs, all to inform people as to how best to live well with cancer. The opinions that are going to be expressed on this webinar don't necessarily represent those of Chris O'Brien Lifehouse, and they're not in place of medical or healthcare professional advice. So let me introduce you guys to David and Santosh. Santosh, who's down the bottom there in his super cool podcast gear, is a medical oncologist at the medical director of integrative medicine for Banner MD Anderson. Dr. Rao is very passionate about incorporating integrative oncology and cancer prevention in cancer care. He serves on the board of the Society of Integrative Oncology as the treasurer, hosts the Integrative Oncology Talks podcast series, teaches integrative medicine fellows at the University of Arizona, has been a leading contributor to educating modules for the cancer curriculum. Professor David Joske is sitting in his clinic room due to commence when we've done, is a clinical haematologist at Sir Charles Gairdner Hospital. His clinical and research interests include treatments of lymphomas, palliative care in haematology and supportive care in cancer. And he's also currently the chairman and the chief medical officer to the Solaris Care Foundation. Now, having said all that and introduced these guys, there's actually a thread that connects us all. I have started working, my background's in palliative and supportive care, and I started working in integrative oncology about 5-6 years ago, and had a real interest in how to best address the whole person care needs of patients living with cancer from the time of diagnosis and on and into survivorship. I joined the Society of Integrative Oncology, and I'm now co-chair of the clinical practice group together with Gabriel Lopez, who unfortunately hasn't made it online to join us today. David Joske and I are part of the executive for the Integrative Oncology group through the Clinical Oncology Society of Australia, which is a national body. And so we work together in that space. And so we thought it would be really interesting to get different perspectives of what integrative oncology actually is. And so I thought I would give everyone a few minutes to really answer a couple of questions. And I'm going to be the facilitator, but you'll notice down the bottom there's a Q&A little spot or chat. And if you could put your questions, type your questions, and we'll have 15 minutes for questions and Q&A at the end of the session. Diana, who's hidden, is going to go through those questions and present some of them, and also tell me when my time's up. So we'll start with Santosh. So Santosh, why do you think integrative oncology, and I'm going to ask two questions to both of you to think about. The first is, why do you think integrative oncology or integrative medicine is so important in comprehensive cancer care and caring for the whole person with cancer? And the second part of the question is why you are so personally so passionate about integrative medicine and oncology care, and what does it mean to you and to your practice?
Well, thanks, Judith, for having me. And, I think that this is an essential question. First of all, I step back and I say, we have to look at cancer as a leading cause of death in the world. And much of it is preventable, at least we think so. So a majority of cancers are influenced by lifestyle and, modifiable behaviors. So I think that that's part of what we talk about in integrative medicine, is how one can empower themselves, and as a healthcare provider, how you can empower patients to make choices that influence their health. And I think that there's been this long-standing dogma that you can't prevent or influence your own health, and we know that's not true. And so I think just taking a step back at even prevention, there's a lot we can do to improve public health, improve personal choices, and we have been successful, at least in America, with smoking rates. Smoking rates have gone down, and lung cancer rates are going down because of that. However, obesity rates are going up, and we see other associated cancers are still rising. So I think that it's very, very important, as we struggle with the enormity of suffering that goes along with diagnoses of cancer, the cost, everything, that we look at what are all the things we can do for ourselves. And integrative medicine, integrative oncology often fills some of those or answers some of those questions. I think when we think of comprehensive cancer care, obviously the term itself, comprehensive, usually in a cancer center, that means that you have every modality available to you. But I think when we really think about treating the whole person with comprehensive care, that certainly has included palliative care, and that's been well accepted. And I think that now integrative oncology is more commonly kind of looked at as part of that comprehensive care model. It may look differently in different places, but the idea that, okay, we're not going to just treat your cancer with radiation and give you chemotherapy. We're going to have experts talk to you about how you eat, what kind of lifestyle you have, and every step of the way give you support, help answer questions that you might have about what you can do for yourself, manage stress, etc. And I think we're only starting to learn how valuable that is. I think that there's still a lot of research that needs to be done, but patients want this kind of care. And that's actually pushing it probably more than anything else. But we're starting to learn more and more that you can really affect outcomes by incorporating different modalities in integrative oncology, which I'll know we'll talk about later. In terms of why I'm so personally passionate about it, like all of us, I've been evolving and changing throughout my career. And I actually, before I even wanted to become a doctor, I became interested in integrative medicine. That just grabbed me. Meditation, yoga. I started getting interested in Ayurveda, which is Indian medicine, and Chinese medicine. And I don't know why, but all of that really fascinated me. And at the same time, I was really fascinated by basic science. So that became very clear to me that I wanted to bridge those two things. So that actually interested me before I ever got interested in oncology. And I came to oncology actually after many years, even in practice. So I specifically, when I decided to be an oncologist, I wanted to focus at least some aspect of my practice on integrative oncology. So that was actually, it predated my interest in oncology. And why am I so passionate about it? I think part of it is that, there's so many times as an oncologist that we can't help people with their ultimate outcome, and that's a struggle too, where certainly everybody's trying to get better at treating patients. But to have the ability to go beyond just what chemotherapy you're giving and just the basics of, this is what I'm doing and I've put in the orders, et cetera, but to be as complete a caregiver as I can be, with skill, with knowledge of how I can help people with what their issues are, their personal issues, which everybody tries to do. But I think some of the tools we have in integrative oncology help. And so that training, I think putting that into practice where I know where certain, complementary therapies might fit in, and learning as much as I can about diet and lifestyle and all those kind of things, it just helps my patients, and it makes me a more complete doctor.
Well, thank you so much, Santosh. I think that was wonderful. I'm going to throw the question to you, David.
Judith,
why do
thank you
think? Yeah.
And thanks for the chance to participate. So to answer why, I think the short answer for me as to why it's important is that patients want it and need it. And so the history for me is that by the late 90s, I was 4 or 5 years into a consultant career. And I reached the conclusion then, which I still have now, which is that in many ways we were doing this business of managing people with cancer pretty badly. Yes, there was great science. Yes, there was fantastic clinical trials, and especially in hematology, it's been an incredible last 10 years. But I just had the feeling as a consultant that I was not doing enough to really help my patients, and that it needed a kind of a wider team or something more than the system could offer. And then it was a chance comment from a patient that triggered a whole personal and professional journey. And the comment was that it was from a guy called Roy, and he was about three cycles into treatment for lymphoma. And he said that it had taken him that long to learn how to be a patient. And I said, well, what do you mean, Roy? And he said, well, when you start out on this, you have to learn the geography of the hospital. And hospitals are always rabbit warrens. I had to learn the language of my disease. I had to learn a bit about the biology of the disease. And then he said, and I had to learn who I could talk to about what I was doing to help myself. And that comment kind of made my ears prick up. And I said, what do you mean? And he said, well, we sit out in the waiting room and we talk to each other and we say, have you tried this treatment? Have you tried that treatment? And then, for heaven's sake, don't tell Dr. X or Nurse Y. They will poo-poo you for trying stuff outside the mainstream. And that for me was the real road to Damascus moment, because it meant if I adopted that attitude, there would always be a barrier between me and my patients. And for me as a physician, that was just totally unacceptable. And so I resolved to start looking into what was then called complementary and alternative medicine. And that kind of put me into the frame of mind of being a doctor who would show an open mind. And the journey has been from there to a doctor, truly, I would hope, with an open mind. So then a chance came from a benefactor to start a cancer centre. And our first centre opened on September the 15th in 2001. And we advertised for complementary therapists. And there was a process we followed to select therapists. We had replies from people who wanted to hang crystals over the patient's chemo bags. And one of the founding principles that I have used then and since is that to to select and credential a complementary therapist in our centres, it had to be someone with whom I could have some kind of shared clinical dialogue. Even if the language were different, there has to be enough common ground to be able to establish a clinical dialogue with a fellow therapist. And the day it opened, it went gangbusters. We had 100 people a week coming into the centre in my hospital. And from there, we've grown to 5 centres. Mostly the model has been to put a centre where there are mainstream cancer services within large cancer centres, and then in rural and regional cancer centres. So we have one in Bunbury, a city of about 100,000 people, and one in Albany down south, a town of about 25,000 people, where there are mainstream cancer centres and chemotherapy being given. And most recently with the virus, we've had to change to an online service model, and that's another story. So for me, I've become very, very passionate about the system needs to be rehumanised. And you can Google a TED talk I gave on this, but I really think at its worst, although the system is well-intentioned, although the people in the mainstream health system are highly trained, at its worst, the system becomes a kind of factory and gives people this terrible feeling that they're just production line fodder. And so with the pressure on the system, nurses and others, the rest of us have less and less time to actually just sit and talk and interact with our patients as people first and foremost, on our part and theirs.
Thank you, Dave.
So for me, the why is about embracing a person in whose care I'm involved as a fellow person who needs all possible avenues of help. And I would say integrative oncology possibly isn't for all people with cancer, but it certainly helps an awful lot of people. And the evidence that we've assembled now over nearly 20 years has been very, very positive.
Thank you, David.
As to the
and
what...
I guess, sorry, the what is coming later.
Okay.
But I would just thank you so much for sharing that. And I think it's really important sometimes to capture why we dedicate ourselves, because it's so much easier just to keep, practicing the way we have within our system, be a haematologist, be a palliative care specialist, a medical oncologist, without investing our energy and our time in really developing integrative oncology, understanding it and looking at ways to bring evidence-based therapies to our patients. And for me, I think I'm driven by the why, in that, we've spent all this energy working out how to keep people living longer with cancer. And I see it as really my duty as a doctor, for me anyway, is to, and as someone working in healthcare, is actually to say, but we need to keep you living well. We need to make this, cancer is something that you need to live with, and we need to empower you and help you to live well from the time of diagnosis, help prevent disease returning, look at ways to manage your symptoms through treatment and from the cancer itself more holistically, have a bigger toolbox. And also the whole concept of survivorship, the fact that now in cancer, and I guess I've been a doctor now for over 30 years, as I think you probably, maybe Santosh, you're a bit younger, but the idea that people, survivorship is this real thing. And I know that, David, you work in that space as well. The idea that people are living post-cancer, living with the fear of recurrence and need to live well. And I think integrative therapies have just such an important space in, and exercise, and I include exercise and lifestyle changes all as a part of our offerings, are just so important in the delivery of cancer care, not just treating the cancer. So I'm going to just go back to the what, and I thought it would be good just to check in with the definition of integrative oncology that was published in 2017 by the Society of Integrative Oncology and published in NCI. Can't remember which journal it's been published in for a second. Santosh,
I think it was JNCI.
Yeah, JNCI, that's right. And I'm just going to read out that definition. Integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practice, natural products, and or lifestyle modification from different traditions alongside conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and clinical outcomes across the cancer care continuum, and to empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. So for me, that definition has really assisted me in integrating this approach into comprehensive cancer care. But I noticed, but I'd be interested in how you feel that definition sits with each of you. And Santosh, in 2018, you wrote a reflective piece, and I'm going to quote from that piece, if that's okay. And you said that, and this is on integrative oncology, that you find it difficult to truly define integrative oncology, that you feel there is something that people recognize as different in an integrative oncology clinic, the ability to synthesize different concepts and perceptions along with different modalities, and to help people navigate the complex and often unregulated world of natural supplements and internet half knowledge. And that the reality is that we are still missing some clarity as to the quality and nature of some of these offerings. So I thought I'd throw that at you, Santosh, to maybe expand on and comment.
Yeah, thanks, Judith. It's such an interesting conversation for me because I really like that definition as well. So I started getting into this field about almost 30 years ago, and I was thinking about this, before this webinar, and thinking about how I would talk about it. And I think that the difference between somebody who was even interested in these things 30 years ago and everybody else was very stark. It was just this thing where either you actually even talked about acupuncture or you didn't. There wasn't a lot of evidence, and it was just very clear. And now, where we are now, it's just so different. In reality, you have people who, are just doing studies on medical cannabis or turmeric. I remember at a different institution I was at, the head of thoracic oncology was doing a study on turmeric as a STAT3 inhibitor. I remember that. He had no interest in integrative medicine per se or any training. Similarly, I know people who are doing research on medical cannabis, on acupuncture, stress management, and it's become very mainstream if you look at it that way, which is great. And at the same time, that makes it hard for us to distinguish ourselves. And that's always been an issue, is how do we define it and how do we distinguish ourselves? The training is not always clear in terms of what qualifies you to say you're an integrative oncologist or an integrative medicine doctor. It's a really big tent, which is great, but it also, as such a big tent, it makes it hard to know who fits in and who doesn't, and what, what is it? If it's so vague, what is it? I think the definition helps. I like the definition. At the same time, just going through this, there's a lot of loaded statements there. So patient-centered. I think that's kind of almost like a criticism of conventional care. But if I wear the hat of a conventional doctor, they would argue that they're patient-centered. I mean, why not, right? There are many, many, many good doctors who don't necessarily ascribe to this particular definition. I think probably the biggest vague one is evidence-informed. To me, that's the real critical piece there. And I personally think everybody has a different definition of what that means. I think that academics have a certain definition of what that means. People who are more just clinicians have a different definition, and patients have a different definition, also depending on what stage of disease they have. And so part of this is navigating where are you going to meet the patient on what line of evidence and how much evidence you feel is necessary before you recommend something. And I'm telling you, every single person has a different approach to that. And that makes it difficult because there's guidelines that get put out. And unfortunately, the evidence is not strong enough for us to really have great strength in what we recommend. It's still not the highest level of evidence. And so different people will have different views on whether you include anything outside that, Class A evidence or whatever, the strongest level. And so that's interesting to me. I think probably the best parts of that definition are what follows, is the philosophy of care. that we're empowering patients. And then I do think that there is something there that people recognize, which is these mind-body practices, natural products, which is, again, some of us, would include some natural products, some not. And then different traditions. We tend to be the people who bring in the Chinese medicine practitioner and include acupuncture in an evidence-based way. We tend to be the people who might bring in a native healer or an Ayurvedic doctor, and it's different in different locations around the world, really. And so it can morph into different things, and I think that's very good. I think we have to remain flexible. At the same time, we have to be inclusive and understand that I think there's this desire to distinguish ourselves, and sometimes that can turn people off too. Because everybody is kind of, I don't know any healthcare practitioner who doesn't want to really help their patients in whole cancer care, for example. Everybody wants to. So we don't have this patent on what it takes to be complete cancer care, but we just tend to know a little bit more about some of these other modalities and how to weave them in. And I think that, without putting it on paper, I think that practitioners know what it is, and I think patients know what it is. And the reason I think it's so important is because people are out there and they get diagnosed, and there's just so much you can read. And you need to have the time, and you need to know the research, basically, and have the training to be able to implement these things in a smart way and really guide your patients. And I feel like that, because there's more evidence growing, we tend to be the people who are focusing and learning on about those pieces of evidence to help our patients know when to use medical cannabis, when, how they can meditate, etc. So, I mean, it's interesting, and I think it's important for us not to be, own it too much. We have to include the fact that anybody can say that they're an integrative practitioner, really.
And I think so thank you. And I think the concept of evidence is interesting. And I think I worked in palliative care for a very long time, and our level of evidence is probably not any better than the level for some drugs that we commonly use, and yet they become mainstream because it's best practice, do no harm, evidence informed. And I think that's the caveat where the evidence informed really makes a difference. You need quite a bit of time, energy, money, and resources to really develop that evidence. And I think the Society of Integrative Oncology is really working towards developing that evidence so that we are actually not just saying acupuncture may help your chemo-induced peripheral neuropathy, but where are the studies? Where are we up to? How are they conducted? How is the sham group chosen? How are the sham points chosen? And so I think as we are developing, we're also developing more robust research to answer that question. It's not just level C evidence or evidence-informed practice, but I think for example, the guidelines on breast cancer and the role of integrative therapies for patients during breast cancer, where you've got some level A evidence for certain therapies, for meditation, for relaxation, or massage therapy, or yoga, for sleep disturbances and cognitive impairment. We're actually getting to a point where there is quite a lot of evidence, but most importantly, we're not causing harm by providing this care. And I think the part of the definition that I really love is the self-empowerment, the self-efficacy. We're helping people also to develop skills that they can take into their post-cancer space and help them through their cancer treatment. And I think it's really important to go back to that term of the whole person, because it is everything we do in medicine now is patient-centered. But when we're talking about caring for the whole person, I think it gives us a space to spend time with the person and go through how, for them, we can help them develop a plan of care, a plan of living, a way of living that enables them to exercise regularly in an evidence-informed way, to safely use herbs and supplements if that's what they're doing, to change their diet safely and effectively that improves their well-being. And some of that is evidence-informed and some of that is evidence-based. And same with, you know, the traditions of Chinese medicine. The level of evidence is steadily growing. So I think it's a really exciting space to be working in. David, do you have any comments? I can talk for too long on this.
Yeah, me too, unfortunately. I absolutely echo both of you. And I think, as Santosh has said, in part, integrative oncology is an attitude. It's an openness. But to expand upon that, my own definition has evolved. And I think for the first whatever years after I started my centre and then centres, to me, integrative oncology back then was the best of both worlds. So if you'll indulge me a little bit of history, Rene Descartes was the start of all of this. His treatise in 1641 was subtitled On the Distinction Between Mind and Body. And Descartes is considered the founder of Western scientific method. And he initiated this whole movement of hypothesis testing, very reductionist, what has evolved into population-based health, and a very rigorous scientific method, which excluded or separated the mind and the body. And the mind-body split has been with us for 300 years. So another example, in 1912, the US government was very concerned about a whole lot of dodgy medical schools starting up. And they commissioned something called the Flexner Report. And the Flexner Report concluded that the US government should only fund those medical schools that taught a physical basis of disease. Very influential. About half of these medical schools closed at that time, quite a few in the UK and therefore in Australia as well. So there was this antipathy, and there was a kind of arrogance to the Western model that said, we know what to do because we do the proper science. And unfortunately, I would argue, in Western medicine, in cancer, we started focusing on the eradication of disease. And so if you look at the history of cancer treatments, the discovery of chemotherapy, the evolution of chemotherapy, certainly in hematology, you know, with the evidence that we could cure some sorts of lymphoma, people tried stronger and stronger and stronger regimens. If chemo is good for you, then more of it must be better for you. And we started pursuing tiny increments in survival curves, and we lost track of, or we lost sight of, the patient's experience of their illness. And that in some ways is a forgivable error, and in some ways it's an unforgivable error. So the Western scientific method and this complementary alternative medical world were seen as mutually exclusive. And yet when I had my experience and decided to look into this, I found more evidence than I expected, admittedly in lesser journals. And when we set our centres up, we pursued mostly massage and touch-based interventions and psychological style interventions. And the evidence has grown. So we know music therapy is particularly good for depression. It turns out massage is particularly good for anxiety. Acupuncture is very good for chemotherapy-induced nausea. We've had requests for our acupuncturists to treat people in ICU, in the emergency department, and a woman with hyperemesis gravidarium, in fact, in the obstetric hospital. So it's evolved, as Santosh has said, from what was a very binary, mutually exclusive world back then. So we've gone away now from what I used to call the best of both worlds, and it is coming back together. And so my new definition is this thing about shifting a focus from the eradication of disease to the patient experience. And the cliche word for this is wellness. And some medical systems like Ayurvedic medicine and Chinese medicine do have a concept of perfect health, which is above and beyond the Western view of having no disease. They're not the same thing at all. And so I think integrative oncology is very much about focusing on where the patient is at in terms of their cancer and its treatment, and saying, well, this is the card of hands that you've been dealt. How can we optimize the situation for you? How can we make your life the best it possibly can be, whether you're going to be cured or not? And I would like to finish by quoting an example of a patient I was looking after who was a retired surgeon, very conservative. And sadly, he had cerebral lymphoma and was dying, and we had run out of treatments to offer, and he was absolutely unable to cope with the situation, what used to be called agitated depression. Couldn't sit with himself. And I suggested to him on a Thursday ward round that he try a visit to the Solaris Centre. And I saw him on Saturday morning, and he'd had a session of Reiki, which is our most controversial therapy still, and was a changed man. And somewhere in that hour of somebody waving their hands over his body, he had come to realise, yes, I'm dying, and what I need to do is get home and spend the maximum possible time with my kids. So that's the kind of thing that we're looking for. We're looking for saying, okay, we've reached this far with our modern medicine. What about the person?
I would like to add to that, I think part of the, as we take the definition further, as we think about what we include and don't include, I think part of it, when we say whole person, is how do we define that? So, David had mentioned Ayurveda, he mentioned Reiki, and there are others as well, other types of modalities. And in those modalities, it's partly how do you define that person and what are the edges of what we consider the things that we need to interact with. So, and that's obviously this is beyond evidence. This becomes more philosophy, actually. Yeah. So Ayurveda in particular, comes from India, and it's based on this concept of balance, but it grows within the Indian culture of, how we view existence. And, there's elements of Ayurveda that deal with spirituality. And as David mentioned, this concept of perfect health, where you're basically living your best life in complete harmony with your individual nature and with the existing nature around you. So that's a philosophy, but it's a different philosophy, and there's science behind that as well. But you almost have to get on board with the philosophy to really have it bear fruit. But in practice, it can help people. And so part of it is when you have these merging philosophies that don't always exist or coexist perfectly well, when do you employ one philosophy versus another? And so it's part of being an integrative oncologist, not being dogmatic about that. Reiki is an amazing example, and we probably don't have time to talk about it at length, but it's so controversial, but it's popular. And I'm a Reiki practitioner myself, and for me it's not a vague kind of placebo type thing, but most people feel like it is. But at the same time, there's lots of basic science supporting some of the mechanisms. So I find those kind of things really fascinating because there is science and there are people who feel benefit. But if you ask the community, they say, well, there's not a lot of evidence, even though there is some, we don't really understand it. And so there's a whole bunch of modalities like that. As David said, that's a particularly controversial one, partly because we don't understand it well enough. But I think part of being an integrative oncologist is being open-minded to say, we don't know everything. And so, and I think people feel like that's true. We don't understand everything.
And I think the advantage, I'm saying thank you, and I'm realizing that we actually only have about 15, 20 minutes left to go. So people with questions, if they start writing them down, I just want to move this forward a little bit. But it's such an interesting discussion, isn't it? And I think I feel confident, I suppose, after 30 years as a doctor, to feel comfortable as to being able to merge things safely, knowing that number one is best practice medicine and number two is best practice integrative therapies, and that's safe. Maybe it's a maturity now within the medical system that we feel safe that you can actually exhale and care for the whole person. What we do see, and I'm going to touch on this just a little bit, and as a way of the how, I guess, in integrative therapies, and this is very much on our work in the Society of Integrative Oncology as well in our clinical practice group, because we look at what we treat, our bread and butter work, which is looking after the person, the lifestyle work, but also looking after the symptoms that they commonly develop that are quite complex and difficult to treat and have very few solutions outside of the integrative oncology space. And thinking about fatigue, it's sleep disturbances, hot flushes, chemo-induced peripheral neuropathy, cancer-related cognitive impairment, anxiety. And I think we were speaking just before we started the session. Most of us use patient-reported outcome measures in clinical practice now, and there's this increased move to identify what's going on for people, these symptom clusters that are so beautifully addressed by certain modalities such as acupuncture, touch therapies, mind-body therapies, exercise, as well as medicinal cannabis, which I don't even have time to talk about today. But building this evidence base is, to me, a very fundamental and important part of demystifying integrative oncology. And I just thought it would be good in the last couple of minutes just to touch on, you know, how important research and systems and structure is to the ongoing integration and acceptance of integrative oncology as a part of holistic supportive care or holistic care for patients with cancer. Long-winded question.
Maybe I'll start that one, Santosh. So I think research is key. If you provide the medical community with evidence, they will respond and change their behaviour. There are caveats, which is that in cancer medicine, we have been wedded to the randomised controlled clinical trial, and it's very hard to do that with a lot of aspects of complementary therapies. In Australia at the moment, yes, we've moved on, but there is still a lot of pushback. And the pushback comes, for example, there's a body of people called the Friends of Science in Medicine who are saying if something doesn't have a scientific rationale, it shouldn't be taught in universities and it shouldn't be allowed to be practiced, basically. And I come back to that arrogance, you know, to say that we know everything now is just oxymoronic. Why do we do research then?
And so where do you think the work in health policy can move this forward? I know the work with the, is this crucial? Is this working to embed research into our practice crucial? I mean, I think it is, but I'm just wondering about your points of view.
First and foremost, we need to ensure the safety of the patient. So unfortunately, I would say in Australia, in the complementary and alternative medical world, this is a very vulnerable group of patients who are sometimes exploited. The second problem is if you put research into the equation, you may kill the goose that lays the golden egg. So when I started my centres, my original plan was to just make patients, offer them the chance to select whichever therapies they wanted. And the plan was after a year or two to start directing them into trials to see if a particular therapy might be best for a particular clinical safety situation or a tumour type or a particular treatment regimen. But then we started realising that when patients walked into our centres and chose a therapy, for many of them, it was often the first time they felt they had been able to make a choice about the management of their condition. And it flicks the switch. And I see this in my own patients who go to the centres and come back. And they have gone from a rabbit in the spotlights to, hang on, I can start to manage the situation. I can start to get some control back. And so this empowerment effect, I think, is terribly, terribly important. And it changes the experience of going through the cancer journey from one of everything bad is happening to me to, okay, I'm managing this. I want to make a plan with my oncologist, hematologist that I understand, that I buy into, that I agree with, and I want my own life plan, my lifestyle management of cancer, which is equally important. And there's this huge appetite amongst people who've been diagnosed with cancer to change their lifestyle. It's a very teachable moment, as they say.
Yeah. Now we've got a few questions. You go on, Santosh, and then we'll
I was going to say, I think research is the key because then everybody gets on board. And then health policy, you know, it's different in different countries. In the US, it tends to be where healthcare is seen in not so much about, you know, what's best for the patient. It's a business. And I think that that's not the case everywhere. But we have to continue to push for integrative oncology to be included, because integrative oncology is efficient, cost-effective, and in some places the most practical option. And so a lot of that, you have to have health policy that supports it so that you can accomplish what most of our goal is, which is just to get, our patients to feel as good as they possibly can.
And we haven't touched on so much, and obviously this conversation, and if you listen to Santosh's podcast, you get a lot of information about the specific therapies and how they can help. And we can talk on different topics at a later date, but I think I'll open it up to questions. So if anyone has a question, either put up your hand, or if Diana, you wanted to read out any of the questions for any of us.
Yes, so we have a couple of questions in the Q&A, and I'd like to start with a question from David Bailey. In practice, do clinicians have the time to have these wide-ranging conversations about complementary and alternative approaches? I think that's an excellent question, so please.
I think some clinicians structure their consultations to allow space for these questions. I think that the reason I'm so pushy and invested in patient-reported outcome measures is it enables you to identify what somebody really wants to talk about before they come in the door. And so your consultation can include, wow, you're really not sleeping well, we really need to talk about this, rather than do tick box, you're okay to have your chemotherapy or go on. I think the benefit of services like our integrative oncology service here is that if they come and see me, they get an hour just talking about symptoms, but not their cancer treatment. So it's looking about symptoms and lifestyle change and how you can best develop a care plan and address those difficult symptoms. We can speak for half an hour on sleep. You can speak about peripheral neuropathy and develop a care plan for that. So the answer is using tools like the patient-reported outcome measures assists, and it helps direct patients to the right people to provide the right care in the right way.
Judith, I find that this is one of the core questions, because in my practice, actually most of the week I practice as a medical oncologist. And then in that particular line of work, I'm really busy. I'm reading scans, I'm talking to my pharmacist, I'm looking at labs, and I have time in front of the patient, but the day is busy. And there are a lot of patients, and it's difficult to have 100% control because you need to see people who are sick. And so, you do your best. But then I have this separate practice, or a day a week, basically, where I do integrative oncology, and I have time. And so I think that it underscores the importance of having maybe some practitioners who are separate from the clinical oncologists who have the extra time to really weigh in on this. I mean, frankly, it can be frustrating as a clinician, because, even though I'm an integrative oncologist, I have so many things I'm trying to do at the same time, and I'm trying to stay on time. And in an ideal world, yes, I would spend an hour with everybody and listen to all their complaints, but that's not always how things work, because I don't want somebody to wait for 3 hours. So I think that actually is a reason to have, the dietitian focus on diet and have an integrative oncologist, a psychologist. That is, it empowers and has us include people into the workspace who have a little bit more time and can really, focus on those things. So I think that's part of this model, where you have certain people who can spend the time. Not everybody can.
So,
Diana, any other questions? Oh, David, sorry.
A couple of comments from me. Firstly, the therapeutic relationship that you build with somebody can facilitate more efficient communication on these matters. So I've structured my practice so that when I am referred a new patient, it's a 45-minute consultation, often goes to an hour. But crucially, the second one is still half an hour at least, because often I'm repeating the bad news information at a time on the second interview where the person's had a chance to get through the emotional reaction to the news and to start to assimilate information. I write stuff down as I'm talking so that they have a record of what I've said, and I encourage them to come back with other family members if they wish. So at the end of those first 2 visits, my patients, I would hope, know that I'm quite happy to be very honest about what's troubling them, which means when they walk in the door 3, 6, 9, 12 months later, they can cut straight to what they really want to say. So I think that that's one way. Making the second appointment longer helps a lot. And then I would say there's no doubt that there's a huge accumulation of knowledge now in integrative oncology, and that is a barrier. You know, our trainees in hematology and medical oncology and radiation oncology, compared to 10 years ago even, they have a whole new body of knowledge of molecular medicine that they have to learn on top of the training of that has been in place for years. So somebody has worked out that if you were to keep current in hematology now, you would need to read 29 hours a day. So that is a barrier for a lot of people practicing in this area, if to say, oh, it's just too much. I'm not going to buy into that. And quite often what follows then is the kind of self-excuse to say, well, it's all rubbish anyway.
Okay, I think, yes, we might take another question here. So this is a question from Sarah, who as a reflexologist, yoga teacher and Reiki practitioner sees the value of people experiencing these modalities for themselves. So her question is, what are your thoughts about introducing opportunities for medical doctors to gain more understanding of what we offer and experiencing these treatments for themselves?
Well, I think that's a reason we're doing this program, and that we offer staff to use these services as well, that we offer patients the services when possible and when we're well funded for free in packages of care, particularly on the wards. I think it's really important for people to experience and practice self-care and to incorporate these practices into their self-care. And I think that's as important as our patient wellness program is our staff wellness program. So I think, thank you for asking that question and raising that concern.
I've lost track of the number of times a medical colleague has come to me and said, my wife, husband, brother, sister, aunt, uncle, father, mother has just been to Solaris and now I get it. So there's this, you're absolutely right, that question is on the money. If we could up the ante for this in medical student training, maybe that would help.
Mm.
Okay, I think...
Ask question?
Yes, we do have. They're coming in here. I'm afraid we probably won't be able to answer all of them. But one thing asked by Chris here is the evidence-based informed paradigm is important, but it risks disempowering the patient who goes to an expert to receive the evidence. So in other words, the treatment gets done to the patient by an expert. How do you foster or develop patient self-efficacy within this paradigm?
I'll go first.
Okay.
First, it gets back to this empowerment thing. In the psychobabble, we talk about the locus of control. And in my personal practice, I envisage, you remember the computer game The Sims with the diamond-shaped thing above the person indicating their mood. I see this locus of control as a diamond-shaped thing that is oscillating between me and my patient, and I'm constantly trying to bat it to the patient. So in other words, if the attitude of the prescribing physician, whatever, and I use that in the wider sense of the word, is to say, here are some choices. The choices for how you manage your illness are these. Which path would you like to take? And then I will talk about the choices they're making, and from my knowledge base, give them advice as best I can. But I think the empowerment thing is crucial.
And I think it's about giving people choices, basically. You know, if you're diagnosed with cancer, you have a lot of stress. It's obviously, we all feel like you should be able to go through this the way you want to. And we know from studies that people do things anyways. And so this is our job, is to give guidance and assistance and not make all the choices. So, many times I'd say half the consults I get are people who are just asking questions. What is safe? What is not safe? This is what I want to do. And then we can kind of, basically help them and say, these are the things that I think you maybe haven't thought of yet, that I think are helpful. And these are the things that I think you really shouldn't do. And I think that context, that nuance of saying, that's not a good idea, because there's often so little evidence, and again, it's different for everybody, but I find that in practice is very, very helpful, and people are looking for that. Should I exercise a ton or should I exercise a little bit? What if I feel a little bit tired and I'm getting chemotherapy? How much should I push myself? It's that extra step of adding some context and expertise to it that is what people are looking for.
Thank you.
Very powerful when it comes from the doctor.
Yeah.
Yeah.
Maybe
and that's a big part of my work. Yeah.
Sorry, I'm just wondering, again, we have a lot of questions here, but maybe just a last sort of practical one that could be interesting for people wanting to engage with integrative oncology. So the question is, should the patient's first consult with an integrative oncologist take place only after a treatment plan has been put in place by the medical/surgical team? Second question, or is it appropriate for a patient to see an integrative oncologist straight after diagnosis whilst treatment plans are still being determined?
Yeah, go on. You go first, Santosh.
I don't think there's ever a right or wrong. I think that, again, there's so many different integrative practitioners, so I think it's up to the patient, first of all. I think that it would be most useful after you know what's going on. As a medical oncologist, I can say sometimes if somebody's giving a clear direction from an integrative standpoint before I have figured out what I'm going to do, because so much of this has to be coordinated and as so much is communicated, it's better if you know what the plan is. I think, if it's a naturopath, for example, they can give some basics. But in an ideal world, because we want to move very fast on the treatment plan, it's important to know the details. Are you metastatic or not? Are you going to get chemotherapy or not? And then build on that to have a fine-tuned integrative plan. But it doesn't mean that you can't see somebody before and they can work on stress management and some of the other issues and just talk to you throughout the journey. There's no perfect time for it from my standpoint.
I guess from my standpoint, I see our service very much as complementing standard care and best practice. And so I like to know what people's treatment plans are. I like to work with them. Say somebody's diagnosed with breast cancer and they're receiving AC chemotherapy followed by paclitaxel. We've got a sense that we know people are going to experience fatigue when they're going to possibly experience peripheral neuropathy, advising them when to start exercising, where is their disease at. So I find it far more useful, first of all, to make people understand that this is complementary therapy and not alternative treatment. So it's really important to understand what treatment is being offered and then how we best help you through that treatment and help you to recover and remain well and strong and engaged with your community and into survivorship. But I think sometimes it's very difficult, and I have a lot of these consults where it's almost I don't want to do chemo, can you offer me something better? A misunderstanding of what integrative oncology is. It's not alternative medicine, it's complementary therapies that enhance your well-being during treatment and after treatment. And so I prefer to know what's going on for somebody and not to be played against, if that makes sense. I think we're actually, any last comments or questions? I think we've actually run out of time, and I'm wondering if we're still going. So it's been an hour. I thank you all. Oh my goodness, we could talk for a long time. So I thank you very much for this time. It's been wonderful. This is the beginning of our series on living well with cancer. Our next, in a couple of weeks' time, we'll have Gail O'Brien, our patient advocate and member of the hospital board and wife of Chris O'Brien, the late Chris O'Brien, talking with Christine, our spiritual care provider, on the spirit of things and the spiritual care and coping. And I think we will be hopefully continuing more of these conversations into the future. I think there's a lot to talk about, a lot. We're very keen for ideas and engagement, and really trying to work together with other series that are being provided to help people understand how best, what integrative oncology, what holistic supportive care has to offer people to keep them living well with cancer. So I'd just like to really thank David and Santosh for your time today.
Thank you.
It's been wonderful.
I look forward to a chance to do this again. A lot to talk about.